Good afternoon, everyone. Welcome to today's Indians sessions on non-invasive brain stimulation. Today we have with us Dr. Shalini, who has done her MD Psychiatry from NIMHANS and also has done postdoctoral fellowship in non-invasive brain stimulation here at NIMHANS. She has extensive research experience in RTMS, and also she has conducted many workshops on non-invasive brain stimulation at NIMHANS. She also continues to conduct such workshops every now and then. So we have with us her, and today she'll be going to take on evidences and practice on transcranial magnetic stimulation. Over to you, Dr. Shalini.
Thank you, Dr. Chetan. Good afternoon, everyone. Today's topic of presentation is on transcranial magnetic stimulation. This particular topic will be presented over Indians in two segments. One is on principles and investigational aspects, which will be presented by me today. And the second segment is on therapeutic applications of TMS, which will be presented by Dr. Muralidharan Keshavan in the coming session on brain stimulation. I've used a couple of images for ease of explanation in the session. So all of these images were obtained from non-copyrighted public domain, mainly from Google Images and Wikipedia Commons. And this would be the outline of today's presentation, where I would like to begin with the working principles, coil types and positioning, stimulation parameters, safety guidelines, potential applications of TMS per se, how it is being utilized as neurophysiological probe, which is the major interest of topic today, as well as future directions. Coming to the working principle, yes, it works on based on two laws of physics, mainly Faraday's law of electromagnetism and secondly, Lenz's law. To explain to you about it, Faraday's law of electromagnetism talks about on the left side of this panel, the screen, you observe that firstly there is an electrical current which is running in a coil, and that when it runs in a time varying fashion, which means it runs in one go and then stops and runs the second time. When it is interruptedly in repetitive fashion, when electric current runs in a coil perpendicular to its plane, electromagnetic field will be induced, and this induced electromagnetic field, when it comes in contact with another coil or another electrical conductor, it can induce these small electrical eddy currents. And when compared to this current, which is the primary source of electricity, which will be in heavy kiloamperes, these eddy currents are of very minimal amperes. They are in fact in a very small number of hundreds of amperes only, whereas these ones would be in thousands and thousands of amperes. And this induced magnetic field is always can be quantified in terms of Tesla. Well, if this is Faraday's law, to apply it for our clinical application, you can extrapolate it this way. There is a TMS coil, magnetic coil, in which electric current passes through, and it induces magnetic field. That magnetic field comes in contact with the brain, and brain is a very potential electrical conductor. So in the brains we have neurons, glial cells, mainly neurons which are inherently excitable, which can when it gets stimulated, it will produce action potential, and it gets depolarized and action potentials are generated. So in this brain, so this induced magnetic field would produce eddy currents, since the brain also has got CSF and blood supply, where there are a lot of ions as well extracellularly. So eddy currents are generated, and that would go and stimulate the axon hillock of each neuron, and depolarization process sets in, and thereby the action potential passes through transsynaptically. if that's about the planes in which the current, electrical current as well as magnetic pulses go, what about the direction? So to explain about direction of electric current, in the coil, if say the electrical current goes in clockwise direction, then the eddy current which is generated when it comes in touch with any conductor, the current generated would be in anti-clockwise direction. And this particular whole principle is explained by Lenz's law. And Lenz's law particularly talks about the direction of eddy current but not magnitude. As we discussed earlier, the magnitude of eddy current is many-fold less when compared to the actual electrical current in the coil. So these are the working principles of TMS. Coming to the origin and evolution of TMS, it is very interesting that how the TMS has come into the picture. So initially, for all the nerve conduction studies which were done both in neurology as well as psychiatry, majorly neurology to begin with, they had earlier this transcranial electrical stimulation was in use, and Merton and Morton were the first ones who had used this procedure where they stimulated it over primary motor cortex. And 5 years later, Barker is the first person who had used Sheffield magnet. This is a magnet which was earlier used for the purpose of peripheral nerve stimulation to look at the nerve conduction, to examine nerve conduction in the peripheral nerves, mainly neuropathies and so on and so forth. So what he had explored was he and his colleagues together, they had increased the output of stimulation, magnetic field strength, and applied those coils over applied that coil over the primary motor cortex and elicited a twitch in the hand muscle. So with that, he came up with the thought that came up with this whole idea that even transcranially, magnetic coils can be used for stimulation purpose. And he is the first one to coin the term transcranial magnetic stimulation. Later, multiple lot of engineers and researchers came into this field where they explored various improved a lot on the way this TMS devices work, and many equipments were designed eventually. And in 1991, the first person, these are the first initial colleagues who have observed, Pascal Leone is the initial one, who and his colleagues who have used TMS pulses, but they had given at a very low frequency and placed it over the Broca's area, which is the area from where motor area of speech, and observed that when the pulses were given at low frequency range repetitively, there was speech arrest in the person who had received it. So this is called a virtual lesion because there is no lesion caused in that brain area, but pulses have gone and caused reduced the activity of Broca's area. And later what was noticed that this effect did not just last as long as the pulses were given, and it outlasted the whole phenomenon, as in it lasted for more than 30 to 40 minutes or after the cessation of our TMS procedure. And this had given a way to repetitive TMS protocols. And eventually Kolbinger is the one who had used it clinically, while Pascal Leone et al. Used it in healthy population. Later, Kolbinger had explored in patient population, where he had given it for major depressive disorder. And in 1996, Pascal Leone and his group have explored its utility in treatment-resistant depression. Then in 1996, eventually after all this RTMS procedure came into the picture, Brown had highlighted the safety concerns about repetitive TMS, because until then it was used for investigational purposes, since the frequency rate is higher than the pulse rate that we give in investigational procedure. Usually in investigational procedure we give one pulse every 5 seconds, whereas in RTMS we give about one pulse every as low as one pulse every 2 seconds to even up to 50 pulses in a second. So there's a wide range of repetitive rate which is noted with pulses. So that had raised a lot of concerns. And Wasserman, this in 1998 there was a conference. In 1996 a conference was held where all the team of researchers world over, they had a committee where they explored the safety of usage of TMS for treatment purposes. So Wasserman's had written and his colleagues written safety guidelines about repetitive TMS in clinical use. And eventually in 2009, which is exactly about a decade later, again the whole TMS consensus group have explored the whole not just clinical, even the research applications of TMS which have been used. They've reviewed all the evidence and laid down the safety guidelines, which was an update actually. Coming to the treatment aspects in 2005, until now we've talked about RTMS, repetitive TMS, whereas there has been an advancement of patent TMS. In patent TMS, one of the very commonly used clinical protocol is theta burst, that was initially discovered in 2005. And there are various manufacturers who have designed TMS devices and which are available in the market. The first one to get approved is Neuronetics in 2009 for treatment purposes. And eventually by 2015, there are total 4 manufacturers which have obtained FDA approval about safety. They are Neuronetics, Brainsway, MagVenture, and MagSteam. Coming to the advantages of TMS over TES, that's how it was initially appreciated. In TES, the electrical current passes through the electrode, which is placed, which is actually an invasive procedure which passes through scalp skull and placed in the cortical area, which is of interest to study. So that had been a conductive procedure, whereas TMS is an inductive procedure where to cross through the skull for the transcranial purpose, there are magnetic pulses which cross through the skull, so which is actually makes it more painless. And with the recent in the last 2 decades, there were advances in the way coils have been designed, so making it more focal. So it generates focal action potential in superficial cortical regions, and thereby it gets transmitted transsynaptically as well. And making it a non-invasive procedure, because of its non-invasiveness, it is pretty safe as opposed to transcranial electrical stimulation, and it is cost effective overall. And for the TMS administration purpose, these are the things which we need to be aware of. The parts: this is TMS stimulator, the device which has got capacitors placed over the motherboard, and here is a TMS coil which has been connected to the stimulator over here. This coil is figure of 8. There are various coil types which we would discuss eventually. And besides this, it can be the TMS stimulation procedure can be integrated with advancement in the technology, such as using the MRI image, structural MRI images of an individual, and utilizing software which is there are various softwares that are available, and you can enter the specific coordinates and locate that particular region using a coil tracker. You can place it over the coil, and then this is the optical camera which picks up the coil position, as well as there would be a subject tracker which is placed around the subject's individual's head, so that it would guide us as to whether we are targeting the brain region accurately, or how much away we are from. So I'll I'm just briefing about it here, but the further details can be taken up in advances of TMS. I'm just getting you oriented for this. About the technical aspects, as I told, the stimulator has this. This is a generic way that I'm trying to explain. Capacitors are placed in the stimulator, and inductor is in the coil. And as and when we press the button, there is one button available here over the stimulator and one over the coil. It is as per the ease of operator's convenience. When you press the switch, there is a hole. The electrical current passes through this whole circuit, and when a pulse goes through from this inductor, the magnetic pulses are induced, and as it comes in proximity with the electrical conductor, it will generate the eddy current. Okay, so as I told, it contains very high, it operates very high current. This is the magnitude of it, 4,000 to 20,000 amperes, and it generates time varying magnetic field. This is of a special mention, where the magnetic field strength is about 1.5 to 3 Tesla, which is close to the conventional, most of the MRI scans which generate the field strength. This is close to that. And the magnetic pulse which is generated, it decays within 1 second time, and the strength of magnetic field also, it declines with the square root of distance. As in, the highest of magnetic field, you would feel it close to the TMS coil, and as the distance passes off, as you move away from the coil, the magnetic field strength decays. And in the Rossi guideline, which I had mentioned, which was published in 2009, it is clearly mentioned that by a distance of 30 centimeters, the magnetic field strength gets nullified, almost zero. These are the various kinds of TMS coil. The first one that Barker had used was circular coil, which was earlier used for the stimulation of peripheral nerves. And but circular coils, if this is the shape of the coil, which means the coil is actually made up of ferromagnetic core. So there is a ferromagnetic core around which the copper wires are placed. The wires are placed around this in circle. And now the current goes through this, and the magnetic pulses are generated perpendicular to the plane of, if this is horizontally placed in 90 degrees angle, perpendicular to this, magnetic pulses are generated. But with this, what happens is, if you have to stimulate a particular region, you'll have to place the circumference of this circular coil on the target region in order to stimulate, because the magnetic field strength is nearly zero in the middle and highest in the circumference, because the core exists here and this is empty. So in order to make it more focal, researchers have come up with this idea of placing two circular coils close to each other, with which the focality, it comes with focality. The highest amount of magnetic pulse is in the middle of this figure of 8, and it makes it more focal, as well as also the the amount of maximal stimulator output required with this coil is less as opposed to circular coil. And most of the clinical trials and research applications also are done largely using figure of 8 coil. There are multiple names to it. The other name, popular name, is butterfly coil, because it appears in the shape of butterfly. And then there are two other coils. The other important point is, though figure of 8 comes with focality, but the magnetic field strength starts decaying, and it has a decent penetration up to about 2 centimeters. So if you are interested to target deeper structures, mainly for say therapeutic purposes, in such case there has been a lot of criticism about figure of 8 coil, that we can just target superficial cortical structures. What about deep cortical structures or subcortical structures? Or if you want to target more neurons in the cortex itself. So for such purposes, there have been two advanced uh, things that have come. One is double cone coil, the other is HEST coil. Talking about double cone coil, it is same as figure of 8, just that here the angle between the two circular coils is 180 degrees. So they are lying actually in the same plane. Whereas in double cone coil, the two circular coils are placed at an angle of 150 degrees. So with this, what happens is the magnetic field generated around this circular coil, imagine that it is in a conical shape, and this is also in a conical shape. So it is called as double cone coil, making these two cones, it's basically about the way the physics have been made. So this gives additional 1 to 2 centimeters depth penetration. And for deeper structures, double cone coil is being explored. And another one, this is quite popular in terms of late, recently only. It is a HEST coil. This looks like a helmet. Here it is called HEST because it appears like the figure of letter alphabet H, and in fact it is also called as HEST because the first time it was discovered in Israel. So in Hebrew, HEST means the alphabet H, where they have in their language the HEST looks like this helmet. So it is also called as HEST coil. The advantage of this is it gives quite deeper penetration, up to 5 to 6 centimeter deep, and the physics of it is quite interesting. While we talk about ferro magnetic core and copper coils in these circular coils and its various combinations, whereas in HEST coil it's all about arrays of all these copper wires that are placed, so making it go deeper into the structure, targeting the deeper brain areas. So that's the physics of it. The important aspects that we need to know also about, not just we have discussed about shape, also the diameter is something which is important. Wider the diameter, so lesser the focality, and also the stimulus dose strength gets influenced. So highest, if you ask me, the highest stimulus dose strength required would be with circular coil, and less would be with figure of 8. And the wider the diameter of the circular coils, then shorter would be the need for stimulus dose strength. And other important things that you would come across when you read up the literature or when you get into practice are these terminologies. One is maximal stimulator output, the other is motor hotspot, the third is resting motor threshold. To explain to you, maximal stimulator output is nothing but the machine, the device, TMS stimulators, maximum capacity to deliver in terms of both its electrical current as well as its magnetic field strength. So it is not for a given individual, we wouldn't use the whole of stimulator output. We use a percentage of it in one particular TMS pulse. So the least percentage of maximal stimulator output required to elicit a twitch, motor twitch, muscle twitch, when you place it over the motor hotspot, when the target region is at rest, is called resting motor threshold. Whereas the motor hotspot is the region of your interest. Most commonly, the first dorsal interosseous of right hand is considered because majority of us are right-handed, and the predominant brain region being our left hemisphere. So in the left primary motor cortex, and particularly the hand region, because I can show you the homunculus in the coming slides, where the hand region represents occupies the pretty large amount, and focality also it helps us in focal stimulation with TMS coil. So that is the motor hotspot which we target. Coming to the resting motor threshold, commonly it is estimated using two techniques. In research setting, it's majorly it is must that we use in combination with electromyography, and in clinical purposes you can use either of them. And one is visual inspection method, where when you place the coil, center of the coil, over the motor hotspot, and you deliver the twitch, you deliver the TMS pulse, and it elicits twitch in the target muscle. Now let us assume, in this condition, let us consider right first dorsal interosseous muscle is a target. When you deliver the TMS pulse and you elicit the twitch, the machine's least percentage of stimulator maximal stimulator output that is required for you to elicit this twitch in the target muscle, when you attempt 10 times, it must elicit at least 5 times minimum. So this is the criteria for resting motor threshold, which means it is not just one go, or we cannot predict. It's something that we'll have to place the coil on the person and run this trial and error in the first place, and then you find out the resting motor threshold. So this visual inspection is where you visually have to observe for the twitch in the target muscle. Whereas EMG, here you place the electromyographic leads over the belly of first dorsal interosseous, and you do a recording where you find minimum of 50 microvolt of MEP amplitude, the motor evoked potential amplitude. Out of 10 consecutive trials, you must be able to elicit minimum 5 times. That would be the resting motor threshold. Well, resting motor threshold is influenced by various factors, beginning with age. As the age increases, the brain volume decreases, and thereby the total number of neurons, gray matter, which is available to get stimulated, is less, thereby needing more percentage of maximal stimulator output, thereby having a more resting motor threshold. So with increasing age, resting motor threshold increases. Likewise, whichever clinical condition where you find gray matter volume decrement, there would be a higher resting motor threshold. Coming to medication, yes, there are certain medications, particularly the ones which increase the which lowers the ability of neurons to get excited or get stimulated, such as most of these anti-epileptic medication, benzodiazepines, have got some influence over the resting motor threshold. Coming to wakefulness, in wakeful state, the brain is more excitable as opposed to sleep. So if when the individual is wakeful, the RMT is lower. If the person is asleep, then the RMT is higher. And then sleep deprivation. Well, sleep deprivation, it is well known that it makes the brain become easily excitable. Thereby, if the individual is sleep deprived, RMT is going to get lowered. This is of major interest when you do in the same person again and again. Say, for example, you consider RTMS as a treatment in patients where the person is posted every day for treatment session. What we often tend to do is we measure the RMT on the day 1 of session, and we tend to extend it for the subsequent treatment sessions as well. But it is very important to note whether the person had slept well the previous night before you begin the treatment, because if the person is sleep deprived, the person must be having a lower RMT on that day, and if you do not re-estimate the RMT and you give the previous RMT dose itself, then which means you're giving higher dose, and thereby it will pose the individual at risk of various adverse effects. Mainly the very untoward one is seizure with TMS. So hence it is always good to check for the adequate sleep, whether the individual had the previous night or not. Coming to physical exercise, this is a bit inconclusive, but it was found that individuals who were into rigorous weightlifting or a lot of physical exercises, they are found to have higher RMT. And then procedure related, yes, the coil position and contact with scalp are two major influencers. If the coil is not placed towards the brain or skull, and the direction of the coil is placed away from it, then you would end up needing, the focality is compromised here, and thereby you would end up needing more stimulator output, and thereby making it more, making your RMT value higher. Then contact with scalp is also pretty important. There shouldn't be much gap between the coil surface as well as scalp. These are the safety guidelines. As I mentioned before, there was a conference workshop held in 96. Subsequent to that, in 1998, we have this safety guidelines, but it talks mainly about repetitive TMS. Subsequently, a decade later, again, the safety TMS consensus group, they have issued safety and ethical consideration of TMS in clinical practice as well as research use. So these are highly recommended reading from my end to you. Well, the contraindications for TMS being, since that, as from Faraday's law, we understood that it's basically the induced magnetic pulses, which generates eddy current, not just in brain. It can generate eddy currents even in other objects, such as if intracranially there is metallic or magnetic or electrical device placed in situ, that would also get generated, making it get either displaced or get heated up because it's getting stimulated. Thereby, it can either burn the device or cause the local tissue injury. And hence, TMS is strictly, absolutely contraindicated in individuals with cochlear implants, deep brain stimulation electrodes placed in situ, and aneurysmal clips. These are often metallic clips. So these all tend to get heated up and get stimulated thereby. So there is absolute contraindication over here. And the other is pacemakers and other implantable medical devices such as defibrillator in situ. So again, these are the other potential conductors which will get stimulated from the induced magnetic pulses, and thereby the ongoing electronic circuitry can get impaired. So even in this population, it is contraindicated. The other ones are something which we need to run a safety screen before considering TMS. One is history of seizure or epilepsy, not just in the individuals, even in the, if there is history of epilepsy even in first degree relative. In such cases, it will pose the individual at risk for seizures. And also it is important to examine the medications the person is on. Tricyclic, clozapine, lithium, these are known medications which lower the seizure threshold, thereby it will pose the person at risk for seizures. Others being history of serious head trauma. In following head trauma, there can be a lot of the brain is in altered state as before, when compared to before. So it might be easily excitable, or there could be certain, if craniotomy is done, there is no skull in place, so the pulses might go deeper, and if we place the coil over the craniotomy scar, it can lead to further complications. Coming to history of substance use, mainly if someone is on if patient is in substance withdrawal state, in such conditions already the brain is easily excitable, it's already in hyperglutamatergic state, so it'll TMS further, it'll add on, as it can increase the risk for seizures. Likewise, stroke again, hemorrhagic is something of concern, but in ischemic, the brain volume available or the neurons available for excitability is less, thereby here RMT would be more. But hemorrhagic, it is of major concern. In hemorrhagic stroke, TMS could be difficult because already there is raised ICT, the neuronal state must be compromised, so it needs to be evaluated case to case basis. Likewise, brain surgery. And we need to be careful about any medical conditions or neurological condition where the individual already has got a risk of seizure as particularly hazardous, and pregnancy as well, because though Rossi guideline says by 30 centimeter it gets nullified, uh, uh, but however the fundus of uterus lies more than 30 centimeters away, but still clinical studies are not done to say the safety has not been proven, except for certain case reports which account for safe uh, delivery of TMS. However, uh, it is considered to be contraindication because long-term outcome of TMS is something yet to be examined in detail, although there are certain follow-up studies. And TMS adult safety screen, this is something adapted from Keel and his colleagues, published in 2001. Uh, we use this screen which has 15 item, which basically runs us through these questionnaire. It is always good practice to screen individual for the safety, the use of TMS. It begins with have you ever had any adverse reaction to TMS, and have you ever had a seizure, likewise ever undergone EEG or had stroke, head injury including neurosurgical intervention, any metallic implant in the brain, any shrapnel clips or any metallic devices, any medical pumps or any implanted devices, as well as ever the individual had severe or frequent headache, because now when we go through the adverse effects of TMS, you would know that this doesn't mean that we shouldn't be giving in this population. It's about except for the absolute contraindication which I mentioned, in other subjects we can still give it, but with lot of supervision and intense management. And whether the person is on medication, and women of childbearing age, we need to check about their any birth control methods that they are taking, and also if family, particularly the first tick their relative, has any history of epilepsy and associated risks. Adverse effects most common is been headache. The nature of headache is quite variable. However, the commonly reported one is in the place where the coil has been placed, because we had discussed that the coil, induced magnetic pulses can induce eddy current in conductor. So in the head region, we have scalp, which has got scalp muscles. Though these are thin flat muscles, but still they are also electrically excitable. So as we give TMS pulses, they also get stimulated at each TMS pulse. So thereby, in certain individuals, they depending upon where we place the coil, if it is close to the scalp muscle or facial muscle. So in the temporal regions, so when we target dorsolateral prefrontal cortex. So in such cases, headache is a common complaint. Also neck pain, because as we manually do it, we place the coil on the head. So sometimes the individual might strain the neck by keeping it in abnormal position. So erect head is something which is strongly advisable. Neck bending shouldn't happen during the procedure. If that is ensured, then the occurrence of neck pain is actually much little. And muscle twitches, as I explained, for headache, muscle twitches can happen if the coil is placed close to face, then or scalp, in because facial muscles also can get twitched. So in such cases, it could be discomforting for the individual receiving it. This is hearing is alarming, but to tell you, it is quite mild and transient as long as the treatment sessions go on, and mainly it is noted with higher frequency TMS pulses, such as RTMS, high frequency RTMS or theta burst. There have been reports of tinnitus in such case. Also, if some hearing loss, mainly in high frequency range, it has been noted, and it doesn't happen with the initial sessions. If the number of with increasing number of treatment sessions, there is likelihood of it, and it is quite transient in nature. If once the treatment session stop, it's noticed to be reversible. However, this area has to be examined. Important thing is to avoid this, what we can do is we can place earplugs in the individual's external auditory meatus to reduce the distress related to these aspects and reducing the chances of its occurrence as well. And TMS also has got its effect on mood and cognition, particularly if the target regions are something like dorsolateral prefrontal cortex. And there are few other adverse effects also, but they are quite less common, such as syncope. Because of prolonged TMS session, the person is placed in, asked to sit for longer time. So there have been reports of syncope, and that needs to be examined. The most concerning side effect of TMS is TMS-induced seizure. The incidence of it to talk, I'm confined to single pulse TMS because I'm going to talk about investigational. Well, you can extrapolate it for RTMS as well, but incidence of TMS-induced seizures in healthy subjects, it's almost there has been no case report, whereas in patients, approximately 20 case reports have been reported. And the proposed mechanism to it is what happens is the pyramidal neurons in the cortex, they get stimulated excessively, and that excitation gets spread to interneurons. And for a transient period, the inhibitory mechanisms in the cortex get cessated, thereby it will pose the person to experience convulsive moments. And mind you, TMS-induced seizure cannot be equated to epilepsy. However, it requires, it warrants, firstly, aborting the seizure when it occurs. Second is to get thorough neurological evaluation done. And if nothing turns up, then it can be, the individual can be, the session can be aborted and need not be taken up. However, when I say it is not equated to epilepsy, it means that the individual need not be started on medication, on any anti-epileptic medication. In our center at NIMHANS, we had experience of one case where the individual is 35 years old, who was otherwise healthy with bipolar disorder. While determining resting motor threshold, the individual had experienced seizure. So interesting part is here he had a family history of epilepsy, as well as he's been on medication like lithium and chlorpromazine, although he never had a seizure premorbidly. And potential uses of TMS would like to broadly classify it as physiological and neuromodulatory. Under physiological, single pulse and paired pulse are the ones which are of interest. Neuromodulatory will be covered in the second segment of TMS topic. So investigational application of TMS, coming to that, TMS can be integrated with electromyographic technique. This is something which I'm going to elaborate in detail, and it can be integrated with EEG and imaging methods as well. Coming to this technique, I would go in this order: procedure, experimental paradigm, safety of this use, findings in various psychiatric disorder, and future directions. Coming to preparation of subject, scalp needs to be clean and dry, and anybody with metallic and magnetic object, firstly, metallic and magnetic object should be kept away from the individual, but if they are in situ, we had already covered that they are contraindicated, and sleep must be ensured before the start of treatment, and use of stimulants is something that we need to have a check on. Coming to the basic steps, firstly, we have to set up the TMS stimulator, and electromyographic leads has to be kept in place over the target muscle, and amplifier is one device which must be used, and coil must be positioned in the direction, the coil facing towards the scalp, towards the skull, and the handle should be held posterolaterally, while the figure of 8 coil part has to lie anteromedially, making 45 degrees angle with the sagittal plane. The shorter axis of the handle must make 45 degrees angle with the sagittal plane. And then we have to locate the motor hotspot and start increasing the dose and find out the minimal dose, which start modulating the dose and find out the minimal dose required to elicit twitch. Or since we are using EMG, we'll have to look for motor evoked potential of 50 microvolt and determine the resting motor threshold, and then we can go ahead with the study protocol. And this is the motor homunculus. So as you could see, this is the motor area. The largest representation is for the hand region, particularly the thumb. So when we place about from the vertex region 5 centimeters away, we place the center of the coil and stimulate this region. And as you know, there is pyramidal decussation. So when we place it on the left primary motor hand region, the twitch will be elicited on the opposite side, which is right first dorsal interosseous. Coming to the experimental paradigm, these are the four broader things which I would like to discuss. One is motor cortical reactivity. So in the EMG recording, which I said amplifier, the amplifier gives the input to the software. In the software, we get to see the EMG recordings this way. So this is the background EMG activity at rest, and the TMS pulse has been given. And after a short while, you see the motor evoked potential. And then there is a gap, and then there is return to the background EMG activity. Thing of interest is latency. The time from TMS pulse delivery to the generation of MEP is called MEP latency, motor evoked potential latency. And in most psychiatric disorder, it was found to be normal. However, MEP latency is prolonged in demyelinating conditions. Because of demyelination, it takes longer time for the MEP to be generated. So MEP is another thing, amplitude. The peak to peak distance that you measure is will give you MEP amplitude. Well, I forgot to tell you, along the x-axis we have time dimension of 100 millisecond, and along y-axis we have measure of MEP amplitude measured in volts. So this is approximately about 1 millivolt. And the silent period is also of interest, which I'll explain later. So the interpretation, how to interpret the single pulse. So here it is single pulse, one single pulse TMS has been given, and then you elicited MEP. So it is interpreted that greater the excitability of brain, which means the individual would have larger amplitude, thereby at a fixed dose. So they would have larger amplitude, and such individuals might have lower RMT. So low RMT means greater excitability. Likewise, lesser the excitability of cortex, then smaller would be the MEP amplitude, and the individual would need more maximal stimulator output, so which means higher RMT. And also we discussed earlier, with age the excitability decreases, thereby they would end up having high RMT. And then paired pulse. To explain to you about paired pulse, we have one is conditioning pulse, then the other is test pulse, and this is the time gap between interpulse interval. Here what happens is, when the test pulse is preceded by a conditioning pulse with varying time interval, say for example 1 to 4 millisecond, if it is the time gap between these two pulses, then it will basically let us examine the GABA A neurotransmission, which is nothing but short. It is also called as this particular pulse paradigm is called as short interval intracortical inhibition, which means we are placing on the same motor region hotspot, and you give this way of these two paired pulses, and you find a particular MEP. Likewise, if the interpulse interval is distance at 100 to 200 millisecond, then it is called long interval intracortical inhibition. The time gap between the two pulses would be larger, and then in intracortical facilitation, the time gap is between 8 to 15 millisecond. I'll explain to you how the MEPs would look. So this is about intracortical. In the same region, you are looking for the inhibitory and excitatory tone of the brain. Whereas you can combine it cortico-cortical as well. You can place one coil over the parietal region and the other on the motor region, and examine in the same hemisphere. Or the other thing you can do is integrating with a peripheral median, preferably median nerve, and combining and looking for short latency afferent inhibition and long latency afferent inhibition when the pulse given at median nerve and also on the motor region are varying spaced with time interval of 20 millisecond and 200 millisecond respectively. Whereas if we can examine the cortical communication across two different hemisphere also, we can place it on right motor cortex, one coil, the other coil on the left motor cortex, and can examine for short latency and long latency hemispheric inhibition if the time interval between the two stimuli is of 10 and 50 millisecond respectively. And this basically tells us about transcallosal communication, the strength of transcallosal inhibition as well. This is about paired pulse. So say this is where here is a single pulse. If this is the MEP that we get with single pulse, when we give paired pulse, conditional and test, with the gap of 3 milliseconds, then the MEP appears this. Because of GABA A neurotransmission, the which is inotropic GABA, so within such short time span, it will basically produce the inhibition over the same cortex, that is why intracortical, and it makes the MEP size go smaller. So this is the MEP which is commonly noted with SICI. And similarly, when the two pulses stimuli are spaced at say 10 milliseconds, so it will generate such high MEP, and this is called intracortical facilitation. And likewise, cortical silent period. In this, what is important is the individual is asked to press a dynamometer or oscilloscope as hard as possible, and you estimate the maximum strength that the person could do. And 10% or 10 to 20% of maximal voluntary contraction we'll have to estimate, and the individual is asked to keep the muscle contracted at that strength continuously. And in the background of that, when a magnetic pulse is given, then there is generation of MEP, and there is also a prolonged silent period, and then return to normal. So this is called cortical silent period, and this basically is determined by GABA B neurotransmission. And here are all the things that we can interpret. The motor threshold and MEP tells us about excitability of cortical pyramidal neurons, whereas short interval intracortical inhibition gives us idea about GABA A neurotransmission, whereas cortical silent period as well as long interval intracortical inhibition tells us about GABA B neurotransmission. And ICF, intracortical facilitation, tells us about, I'm sorry about this spelling mistake, it is NMDAR, glutamatergic neurotransmission, whereas IHI, interhemispheric inhibition, would tell us about transcallosal communication. And these are the findings, summary of findings in various psychiatric disorder, what happens in each of the respective disorders to this. I'll just take example of one. So MEP is very high in Alzheimer's, whereas MEP is, motor threshold is very low in Alzheimer's disease, which means the brain is more excitable because of lack of inhibitory neurotransmission, essentially, in this condition. And likewise, this is for various, in the interest of time, I'm running through it. This is another experimental paradigm, which is mirror neuron activity, where, say, this is the MEP potential which is noted when the individual is viewing a static image. And so, which means this is at rest, and followed by when the individual is asked to observe the conventional motor paradigm, which is, say, a lock and key. Here, there is only lock and key which is kept aside, and hand, and here the video is run where the individual is performing that particular action. So the principle of motor neuron is either the very thought of it, or while observing that action, these neurons get recruited additionally. So you can see that the MEP is increased in size here while observing this video, and the difference of these two would give us the amount of mirror neuron activity. Likewise, we can add one more element also, where emotion embedded. Here in this, this is basically about a video where a child gets stuck inside and mother gets panicking, and she tries to unlock the door. So here also you see that in emotionally aroused situation, the mirror neuron get recruited. This is mainly in association with social cognition, we can examine these things. Then is cortical plasticity. We are aware of, there are various protocols that we know, neuromodulatory techniques that can generate, like cathode, low frequency RTMS, continuous theta burst, cathodal TDCS, and PAS of interstimuli interval of 10 milliseconds. These are all known to cause long-term depression, which means the brain would, that particular region would become less active over time, during and following this stimulation of the brain, while high frequency RTMS, intermittent theta burst, anodal TDCS, and paired associative stimulation of interstimular interval of 25 millisecond is known to cause long-term potentiation. But to examine this, what we can do is using TMS EMG technique. Before starting, say for example, let us take cathodal TDCS. Before starting the cathodal TDCS, we can examine the cortical reactivity, giving the pulses, record MEPs, and then give cathodal TDCS. Immediately after the stop of cathodal TDCS, you can record at regular intervals the motor reactivity, motor cortical reactivity, and you would see that over time the brain would start showing declining reactivity. That is what is expected, because following this treatment there has to be depression in the reactivity. So long-term depression and long-term potentiation, these are the cortical plasticity protocol that we can examine. Take home would be TMS is a non-invasive procedure, painless, and it has got focal cortical stimulatory method. And safety screen is must for all individuals, whether they are healthy or whether they are patients. But whoever undergoes TMS will have to run safety screen, and that is mandatory. And we have also looked at how it has very potential neurophysiological probe. We can look at the physiological processes of the brain, like the excitability, inhibitory potentials, the connectivity, strength of connectivity, these things. And though we run all this experimental paradigm, to make it more meaningful, we'll have to have a clear question, either clinical or with cognitive outcome. Then only it will, whatever findings we get, it would be explainable, and also it will make the whole exercise meaningful. And my acknowledgement to the whole students and faculty of Department of Psychiatry in NIMHANS. Thank you.
Thank you, Dr. Shalini, for the lucid presentation on both the procedure and investigational paradigms of RTMS. Now the floor is open for discussion. We already have a few questions with us. Dr. Aishwarya has asked, is a past history of stroke an absolute contraindication for RTMS?
Not really. It's not an absolute contraindication. It is a relative contraindication though. When I say relative, it means that we'll have to reassess the individual whether there would be any likelihood of seizures or not. Firstly, most of the patients on stroke, you'll have to firstly look at whether the nature of the stroke is hemorrhagic or ischemic. If it is ischemic, there is no contraindication, just that the target region is less excitable. We cannot target that region. Say for example, post-stroke depression, if the stroke is involved even left dorsolateral prefrontal cortex, it is of no point targeting that region. Then you'll have to switch over to the right side, which is excitable. So this is one. But however, this is about ischemic. But if it is hemorrhagic, there is already, as per Monro-Kelly hypothesis, so if there is brain blood, if there is increase in blood volume, then the brain parenchyma is already pressed, and also there is strain on the CSF as well. So with this, the brain would be more excitable, A. And B is more excitable, so thereby there is risk of seizures in such case, and hence it is always good to avoid and ensure that the person is on has got good hypertension control, as well as even on anti-epileptic from neurology side, not that we prescribe for the sake of TMS. If these things are there, we can safely give it, but there's always something that we'll have to watch out for. So hemorrhagic stroke, I think it is not that safe. However, we can still give it given if there is more of benefit than risk, then we can consider. But from the guidelines, it is a relative contraindication, hemorrhagic stroke. Ischemic, we can still give. Are the diameter of coil and stimulus strength inversely proportional? Yes. As the coil diameter increases, then the not stimulus strength, the RMT for the person is lesser, because the induced magnetic field strength is more. More diameter means there's more iron core which is available, ferromagnetic core that is available, and more copper wiring, and thereby proportionally the field strength would increase. Thereby the RMT value, the machine stimulator percentage wise, if you see, it is less that way. Is craniotomy an absolute contraindication? No, it is not an absolute contraindication. It is a relative contraindication. You can spare that craniotomy scar region while placing the coil. that way we can do, and also ensure that the person has on good anti-edema measures, as well as that on good anti-epileptic if there was a need. So these things to be ensured.
Yes, Dr. Archana.
Hello, ma'am. I would just like to know the effect of RTMS with regard to Parkinson's disease. So what happens to the frequency, because the patients are already elderly, so the volume of the gray matter is already reduced, and there should be some deep penetration also for restriction of tremors or something. So how is it you go about in patients, and has it proven to be effective? Because here some private practitioners are still using it for the tremors in Parkinson's, but I really don't know whether it is making any difference or.
Okay. Thank you for the question, Archana. I had not covered that point today because it comes under therapeutic application of TMS, which is kept for the coming session. However, to answer your question, in terms of its evidence in Parkinson's, it is not FDA approved, which means the treatment protocols are all still under research. And about effectiveness, I firsthand did not have any experience giving TMS for tremors, particularly Parkinson's. However, theoretically, I can answer though. As you rightly pointed out, there is already cortical gray matter volume reduction, but in Parkinson, there is not much of though. However, in Parkinson's also, we do not target the subcortical region, mainly basal ganglia, though there is pathology in the whole basal ganglia circuit, but we cannot, TMS coil doesn't go that deeper. So usually cortical markers are picked up even in psychiatric disorders. Say for example, in depression, dorsolateral prefrontal cortex is the target region, and then in schizophrenia for auditory hallucination, temporoparietal junction. So always we pick up the cortical brain region and we focus, try to give and we deliver TMS treatment protocols on cortical brain regions. It doesn't mean that it corrects only here. So the point over here is, when we target this cortical brain region, it has got connections deeper to subcortical structures. So through this, as we discussed, as I pointed earlier, that it transmits this action potential transsynaptically. So it will cause neuromodulatory changes even in distant regions. So when I say DLPFC, it doesn't mean that it does something to DLPFC. The connections that DLPFC has got to various brain regions, say for example, thalamic structures, basal ganglia, and then other cortical regions, there where it brings up all the changes, and thereby the outcome, clinical outcome, the symptom reduction you get to see. It's not just the target region that you target, that it is implicated in the pathophysiology as a cause. It's about finding out the cortical marker, which you can potentially consider as a target region for this treatment protocol.
If others don't have a question, Shalini, may I ask a question?
Yes, sir, please.
What would be the maximum depth that can be reached in TMS?
Okay. Depth wise, it can go until 30 centimeters, sir. But the strength that we need, that can go up to, with figure of 8 coil, about 2 centimeters, though some certain manufacturers claim to be 3 centimeters. We can, with conviction, with all the experience, we can consider it as 2 centimeters. But with various designs, newer designs that have come in all these TMS coils, such as double cone coil, can give us up to 4 centimeters. Figure of this H coil can let us go until as deep as about 6 centimeters.
8.
So yeah, 8 also they claim, but we can consider, or it's good to consider the lower limit itself.
So somewhere between 2 to 5 centimeters is the maximum depth that is using RTMS.
Yeah.
So this also was in continuation to what Dr. Archana was asking, as to whether to reach basal ganglia or whether to reach other structures. They are so deep inside the cortical structures that it is almost impossible to reach those situations. So what we are seeing is only about 2 centimeter to 3 centimeter. So we are looking at superficial cortical regions, not exactly deeper structures. So
In
even
fact,
if
H coil, there are various designs. H1 to their number till 7, I guess. Each numbers have got were designed for a particular cortical region. So there is one of these 7 is been designed for anterior cingulate cortex, which is actually deep seated. So it can target as deep as anterior cingulate cortex, as well as the as deep as motor homunculus. You would have noticed that in the midline it is quite deeply situated, where the leg region is quite deeply situated. So double cone coil can be used to elicit muscle twitch in our leg muscles, calf muscles as well. So double cone coil and H coil can be used, but a routine figure of 8 coil doesn't go that deeper. It doesn't very hard to elicit leg motor threshold using figure of 8.
yeah, yeah. Thank you. And even if we want to reach any structure which is deep, probably it would be better if we use neuronavigation technique and
Yeah,
then get the actual location of the cortical structure, and then probably stimulate or depress it rather than blindly doing it. Because as Dr. Rachna was telling, like when there is gray matter shrinkage in persons with old age, or even in dementia with Parkinson's and all, it might be difficult to know where exactly the location of so in such situation, probably it would be better to use neuronavigation.
yeah, very true, sir. There's one more point to add also to it. So when we target deeper structure, the compromise over here is, if for this magnetic pulse to reach deeper structure, it would stimulate the structures which are above that deeper target as well. So what would happen is, if we use double cone coil, if say we are targeting anterior cingulate cortex using double cone coil, it will deliver the desired treatment dose to that deeper target area, but the brain region which is just above that target area would receive higher doses. So that is something which would be of disadvantage. If we try to go deeper, the superficial structures will also get would receive pulses and also of higher dose. So with this method, there is this one flaw. However, H coil, they claim that it will ensure that the field strength would be of same both for superficial as well as deeper structure. So if we give 100% RMT for anterior cingulate cortex using double cone coil, so the brain region just above it, when ventromedial cortex, prefrontal cortex, and dorsomedial, they would receive more than 100% RMT. So that is one disadvantage with double cone. Whereas in H coil, all the structures would evenly receive 100% RMT if we are giving. So that's how it's being marketed as well.
Dr. Aishwarya has asked another question. Can you please explain motor hotspot again?
Okay. So the hand region, the target muscle, if it is our first dorsal interosseous, so its localization in the primary motor cortex where we locate, that is called motor hotspot. So when we begin localizing the motor hotspot, we place it approximately 5 centimeters lateral to the vertex. So as you place the coil, immediately we may not find, most cases you would find the motor hotspot, but in certain cases we'll have to navigate through that region and locate. So the final point which you conclude that this is the point which delivers, which elicits muscle twitch, is something that you finalize, and that is called motor hotspot. So there, after you localize, then you will have to start estimating the resting motor threshold by manipulating the percentage of stimulator output and determine the resting motor threshold. Thank you.
Thank you, Dr. Shalini, for your lucid presentation. We also like to thank Linux Laboratories Chennai for their support through educational grant. Thank you, one and all.